Bronte Ballin. I am a fourth-year medical student at Wake Forest School of Medicine, and today we are going to be talking about feeding tube placements and their complications. This is a part of the Radiology Scholars Certificate Program. The learning objectives for this presentation is to understand the differences between gastric suction catheters and feeding tubes in terms of their uses, indications, and their appearance on imaging, to make sure we can identify a properly positioned feeding tube and an improperly positioned feeding tube, and then to learn the risks of improperly positioned feeding tubes. So the first thing I wanted to discuss was the basic differences between gastric suction catheters and feeding tubes. So both can be orogastric or nasogastric, which is terminology that describes where the tube originates from. So it can either originate from the mouth or from the nose, but both will go down the esophagus and enter into the stomach or small intestines. So a gastric suction catheter is used to decompress the stomach by suctioning out the gastric contents. So some of the indications for this catheter are small bowel obstruction, toxic ingestion, severe nausea and vomiting, anything in which the patient would benefit from having their gastric contents removed from the stomach. So the desired location for this catheter is understandably the stomach, as that's where you're trying to remove the contents from. A feeding tube is used to deliver nutrients to the patients who are unable to maintain their oral intake to meet their metabolic demand. So indications for this is failure to thrive, or if they have dysphagia, so it's a little bit harder for them to swallow food, or stricture for the same reasons. So the desired location for this is actually post-pyloric. So it's in the small bowel with the goal of being near the duodenojejunal junction, and this is so that it decreases the risk of aspiration. So on this slide, we'll talk about the difference between a gastric suction catheter and a feeding tube on x-rays. So on the left, we have an x-ray of a gastric suction catheter. These tubes are produced with a radiopaque line down one side of it so that you're able to see them better on x-ray. The blue arrow in the image is pointing to the tip of the tube, and the red arrow is pointing to one of the side ports on the tube. You can tell that this is a port on imaging because there is a gap in that radiopaque line, and that's how you know where the suction port is. Ideally, both the tip of the catheter and the suction port should be located in the stomach. Now, on the right, we have a feeding tube. These feeding tubes often have a weighted tip, and this aids in navigating the tube through that pylorus into its ideal location post-pyloric. These weighted tips can be different shapes, so the white arrow is pointing to a weighted tip that is rectangular, and the yellow arrow is pointing to a weighted tip that is bullet-shaped. The position of a feeding tube is extremely crucial to its proper functioning, and the key to determining if a feeding tube is properly positioned on imaging is to follow its course rather than just looking at where the tip is. So to help orient you, in a patient with standard anatomy, the duodenal bulb is reliably to the right of the spine and is held in place by the hepatoduodenal ligament, and the ligament of Treitz is reliably to the left of the spine. These are really important landmarks that we'll use as we're tracing the course of the feeding tube. So starting at the top of the image and moving downwards following the course of the tube should remain midline when it's in the esophagus. This is the segment colored in blue. It should then course to the left of the midline into the stomach, which is the segment in red. Then it travels to the right of the midline to enter the first segment of the duodenum or the duodenal bulb, which is colored in green. It will then travel inferiorly to the second segment of the duodenum, which is colored in yellow. It then courses back to the left of the midline in the third segment, which is purple, and then travels superiorly from there in the fourth segment to reach the DJ junction at the ligament of Treitz. This is the ideal location for the feeding tube, as we discussed previously. If a tube stays to the left of the midline in the abdomen, it is likely still in the stomach. So next we're going to be talking about malpositioned feeding tubes. So on this slide, you can see some examples of feeding tubes within the airway. You can see that there is this deviation from the midline at the level of the carina, indicating that the feeding tube is actually not coursing through the esophagus, but through the trachea. In the left case, notice how the tube is very distal in the airway. It's likely in the left lower subsegmental bronchus or a terminal bronchiole. The tube is more proximal in the middle and right examples. The further the tube is in the airway, the more dangerous it becomes because As the bronchi and bronchiole get smaller and smaller, they're more likely to be injured by the tube placement or removal, in which the most concerning complication could be a pneumothorax. Speaking of pneumothorax as a concerning complication of malpositioned feeding tubes, this is an example of a tube that was placed in the airway that ended up rupturing into the pleural space and resulting in a right-sided pneumothorax, as you can see by the white arrows denoting the lining of the lung that is now compressed. This patient required a chest tube and careful removal of the feeding tube by the cardiothoracic team. One other thing to watch out for with the feeding tube placement is the potential for intracranial placement in patients with severe facial and skull-based trauma. In the event that a feeding tube is necessary for a patient with the severe facial or skull-based trauma, it is extremely important for a feeding tube to be placed under image guidance to ensure that the tube doesn't extend through the fracture defects into the sinus or cranial vault. Thank you so much for watching. That is the end of this video, but if you have more interest in learning about different radiology-related content, please visit our channel where you can learn more.